All right, we are going to get going with our Face the Case live. For those of you who may have seen it, Face the Case is a social media initiative put on by PRS Global Open that's been going on for the last year or so. The way today is going to work is we're going to have 3 cases. We're going to present the case. We're going to ask you to vote live on which option you would choose to proceed with. And then we're going to have an expert, Dr. Dayan, who is going to then speak about the case and what he would proceed with. Just a couple things, just to know Face the Case has won major publishing awards despite only being on the social media circuit for the last about year and a half. This is our very first Face the Case live, so thank you for joining us. Hang out until the end of today's presentation because there will be a raffle draw for a $100 Amazon ticket. Donnell will be coming around and handing those out, so make sure you get yourself one of those red tickets. You can see all of today's cases at prsglobalopen.com for free, in addition to the entire compendium published by PRS Global Open. And today I am thrilled to introduce Dr. Joseph Dayan, who is a plastic and reconstructive surgeon at Memorial Sloan Kettering in New York. He specializes in microsurgical breast reconstruction, head and neck, and lymphedema surgery. So in order to vote live, text Face the Case 383 to 2233. So if you want to text that now, as we're going through the cases, you're going to see options A and option B. And so you can just text A or B, depending which one you would choose based on the case. And we'll have live voting and polling. So I'll just leave that out there for a quick second so everyone can kind of send that text message off. And without further ado, we'll get going with our first case. So our first case summary is that of a 37-year-old female who develops fever, erythema, pain, and crepitus over her abdominal skin and native breast skin flaps 4 days after bilateral DIEP breast reconstruction. Extensive infectious workup is negative, and her blood work is unremarkable. CT scan performed on post-operative day 5 shows only operative changes and a small abdominal dehiscence, and puric antibiotics have been started. Our problem list for this case is a clinically sick patient with painful erythematous incisions with crepitus, small area of dehiscence, and partial abdominal skin necrosis 4 days following DIEP breast reconstruction. Infectious workup thus far is negative. How would you face the case? Would you take the patient back for immediate debridement in the operating room? Or would you get a dermatology consult given the negative infectious workup and possible dermatologic etiology? For those of you who haven't, text Face the Case 383 to 2233, and you can start with answering A or B now. So A again was in back to the OR for immediate debridement. B was getting a dermatology consult. Everyone who hasn't voted, I'll give another 10 seconds just to get your votes in. And your votes are in. Most of you chose take back to the OR for immediate debridement. Dr. Dayan, would you mind telling us what you would do in this case?
I've seen Pyoderma 3 times. She definitely is sick, and you definitely you can't miss a necrotizing soft tissue infection. And this doesn't look like exactly like classic Pyoderma where you might see this Swiss cheese appearance through the skin. It's an appearance you don't forget. One of my fellows this past year picked it up. She picked it up right away. I was very impressed. This doesn't have that. It looks ischemic and possibly infectious, and the patient's a little sick. Depending on the clinical scenario, if she was septic, I would definitely debride it. But honestly, because this is bizarre, I would have derm weigh in. If she hasn't responded to antibiotics, I would have them on board. But if the patient was sick, I would tend to go back and debride it. If you actually look at it, it doesn't. If this is progressing rapidly, I would go and take her to the OR, even though that might be the wrong thing if it is Pyoderma.
But definitely a safe rather than sorry approach, potentially.
Yeah, but I think you can't know until you're actually there. So if this is sort of lingering, you're trying antibiotics and nothing's really moving in any direction, I wouldn't debride it because it hasn't fully declared itself. If the patient's okay and stable, I would get a biopsy because it does look not typical for an infection.
Wonderful. Any questions or thoughts before we move on to the second part of this case from the audience? No? So I think everyone kind of agreed with Dr. Dayan, kind of going ahead and going with the take back to the OR. Just to make this a little bit more difficult, over the next 5 months, this patient finally achieves wound closure after months of vacuum-assisted closure. Once she is finally healed, she now desires to have revision of her abdominal scar because she's unhappy with this scarring after this Pyoderma Grangrenosum. So our new problem list for the second part of this case is cribriform scarring of the abdominal wound following DIP breast reconstruction, who's being treated and has had significant post-op complications with Pyoderma Grangrenosum. In this part of the case, would you recommend avoiding future surgery given her history of PG following an OR, or would you proceed potentially cautiously with revision after getting steroid recommendations from dermatology? Again, vote now, A or B. Another 10 seconds for those of you who are still deciding. All right, we'll close that and move on. How would you approach the second part of the case here? She's now 5 months out, unhappy with the look of her abdomen. Looking for a revision.
Like I said, I think I would refer it back to you. And then refer it to dermatology. I mean, I think this is largely driven by the patient and is a very sober discussion about risks and benefits because you don't have a series of 100 of these and a ton of data to really go by. So I would let the patient know that it's, potentially fraught with a complication she already had. Things could potentially get worse or better. But we have done revision with the specialty services on board with pulse steroids successfully, but that's only 2 cases. But I would proceed very carefully. If the patient was really upset and distraught, I would just have a sober discussion with her, letting her know that I really couldn't predict how it would unfold, but probably we could blunt the response with steroids prescribed by dermatology or rheum.
Absolutely. Wonderful. Any further questions at this point? This is going to wrap up the first of our 3 cases. So any audience questions about this case, Pyoderma Grangrenosum? Could be a DIEP breast recon question. Wonderful. If not, we're going to move on to the second case presented by Dr. Friedman.
Thanks. So our second case is an aesthetic case. It's something we all see, a patient coming in. She's 21 years old. She asks about breast reduction. She has no history of pregnancy or breastfeeding, no major weight fluctuations. She feels that her breasts are heavy and is worried that they will sag like her mother's. She has a fit, narrow body frame. Calculated BMI is 24. Her breasts are large, firm, and considerably wide across her chest wall. Her measurements are right breast, sternal notch to nipple 34, nipple to IMF 12, and left breast, sternal notch to nipple 35, nipple to IMF 13. The problem list consists of aesthetic breast reduction for large breasts to fit a narrow body frame. How would you treat a young versus an older patient in this situation? Our question to you is, how would you face this case? A, reductive breast using a WISE pattern breast reduction. B, use a vertical scar breast reduction. Vote now, A or B. Very enthusiastic. I see more people treat breasts than PG. Here we go. So, Dr. Dayan, how would you face this case?
I mean, at 21 years old with that amount of ptosis and laxity, I would be concerned about her long-term outcome 10, 20 years later. I mean, she's very, very loose and ptotic at a very young age. I would probably tend toward a supramedial pedicle wise pattern reduction, and see if I could do some auto augmentation, because that tissue is going to be pretty soft and loose. That's what I would do. But I know there are many ways to cut. There's like 24 ways to make this work well, but the nipple to fold distance, if too long over a long period of time, I would worry that would bottom out. It's just he's so lax at 21, so that would be my main concern, is long-term outcome.
And how would you manage the patient's expectations regarding long-term pregnancies, weight fluctuations?
Very good question. I mean, I would say that she would likely need a revision down the road some point in her life, and all of these things are going to affect the size and shape of her breast, potentially exacerbate any asymmetries that she may have, but all important points to discuss with the patient.
Great choice. So we have all of our cases on prsglobalopen.com. Feel free to go read. In this particular case, different method was used, which is interesting in that it uses inferior wedge central resection and restructuring of the breast using the auto-augmentation and the patient's own breast tissue, simultaneously narrowing the breast. Thank you, Dr. Dayan, for the points.
No, I wanted to add, I liked the technique that you pointed out here, which I've never seen before, which is really recruiting the lateral breast tissue in these wide breasts, where it may be hard to narrow the breast if you're taking most of the tissue down inferiorly or laterally and recruiting that, but you take the lateral pillar and actually anchor it to the chest wall, and then imbricate the rest of the lateral pillar with the medial pillar, and then offload tension on the skin. So it is an interesting technique I'd be interested to look into further for sure.
Thank you, and we have a video online. So without further ado.
So our next case involves a 50-year-old patient who presents with bilateral maxillary osteonecrosis secondary to long-term bisphosphonate use. Bisphosphonate-related osteonecrosis of the jaw is a known adverse effect of bisphosphonate therapy. Our problem list includes bilateral bone exposure of the necrotic maxilla and 2 segmental defects with a floating maxilla connected only to the vomer. How would you face the case? A, debridement of the necrotic maxilla and reconstruction with a free fibula flap, or B, debridement of necrotic maxilla and reconstruction with a free scapula flap? Cast your votes now. You can text face the case 3833 to vote if you haven't already, and then answer A or B depending on what you think in terms of how you'd face the case. So it looks like we have a leader, reconstruction with free fibula flap. Dr. Dayan, how would you face the case?
This is a really hard case. I think total maxillary reconstruction I would do with using virtual surgical planning and a free fibula, osteocutaneous flap, and immediate osseointegration. But something like this to get the occlusion right, to get the projection of the maxilla correct, I would feel most comfortable with virtual surgical planning, especially with the osseointegration. Scapula tip has a nice natural shape for the maxillary arch, but I think you get a better bone stock for the implants with the fibula, but it's dealer's choice.
Can you tell us a little bit about when you might use the scapula in your algorithm for head and neck reconstruction?
Well, I think scapula provides a ton of soft tissue. So For more complex defects, I'd need chimeric flaps and so forth. I mean, that whole parascapular system gives you, tons of soft tissue options. So I think it's a much more flexible flap. The skin paddle of the fibula is pretty restricted.
Any questions from the audience?
Oh, one more thing. If the patient has atherosclerosis or a peroneal arteria magna or something, any problem with lower extremity circulation, I'll never use the lower limb, and that's when I think I would definitely go to the scapula.
So in that case, do you generally go to the scapula? Do you ever use iliac crest?
I think iliac crest is hard for maxillary reconstruction, and I have used the iliac crest, but more for mandible. It's great bone stock. It's more limited, less versatility because of the pedicle and the skin paddle. But I think the scapula is a nice option, secondary option for me for maxilla.
Awesome, thanks. Well, in that case, I'll invite Donnell up to do the draw and announce our winner.
Oh.
Can we get a round of applause for our resident ambassadors and Dr. Dayan?